Okay, so section 3B. This morning, the topic is all about drugs for dyslipidemia. In this regard, we will be discussing the agents that can be used to alter or to modify blood lipid levels. Let me remind you that the knowledge that you attained or you garnered in biochemistry about lipids will be applied here. So hopefully yung basic knowledge natin about lipids ay ma-retrieve natin. Okay? Tutulungan ko kayo para ma-retrieve yung mga knowledge na na-discuss natin before. This topic is divided into 5 parts. Number 1, we will recall what lipids are. And then second, concept on lipoproteins. Next, number 3, we will discuss how the body manages or handles lipids. Paano ba natin na maintain ang normal blood lipid levels and also paano siya na-utilize na maayos. And then number 4, in certain cases, if there are problems, ano yung mga goals natin to normalize abnormalities. And then finally, drugs, medications that can be used to correct abnormality in blood lipid levels. Okay? So start tayo everyone with number 1, recall on lipids as biomolecules. As we remember, lipids are basically biomolecules that are soluble in organic solvents and are insoluble in water. We determined lipids before as compounds na as long as sila ay insoluble sa tubig at miscible sa organic solvents, lipids na sila. Okay? And mostly these compounds are rich in hydrocarbon. Okay? Hydrocarbon bonds. Diba in organic chem, pag hydrocarbons, hindi talaga sila polar or non-polar sila. That's why they are insoluble or immiscible with water. Now, natatandaan nyo ba sa biochem dati na ang lipids pwedeng ma-hydrolyze at pwedeng hindi ma-hydrolyze? Can you recall this in biochem before? So hopefully, some of you can remember this. So we have different classifications of lipids based on susceptibility to hydrolysis. Number 1 is hydrolyzable or hydrolyzable lipids. So when we say hydrolyzable lipids, this can be broken down into derivatives through the chemical reaction called hydrolysis. In the body, when we focus inside the body, we have certain enzymes responsible in facilitating hydrolysis. In particular, this hydrolysis of lipids, particularly these are so-called as lipases or lipoprotein lipases. Okay? Ang specific example natin ng hydrolyzable lipid na applicable sa discussion natin this morning are the triglycerides. Remember that triglycerides are also known as tags. Okay? These are also known as tags. What does tag mean? Ano meaning ng tag? Ano yung T? Ano yung T? Very good. So we have triacylglycerol. Now, what's the reason why triglycerides are hydrolyzable? This tells something about the chemical structure of triglycerides. Di ba sabi natin before, ang mga triglycerides kaya sila hydrolyzable kasi meron silang functional group called E. Ano yung E na yon? Yes, that's right. So, meron silang ester. So, ester-containing sila. Congratulations. It's been a year, pero you can still remember. Okay? So, congratulations. So, these are ester-containing compounds. So, that's why hydrolyzable sila kasi upon hydrolysis through lipoprotein lipase, this results in the formation of what you call as FFA. So anong ibig sabihin ng FFA? That means free fatty acids. Okay, yung free fatty acids. And also we have glycerol. Question, kapag na-hydrolyze ang triglycerides, how many free fatty acids are extracted? Yes, that's right. So 3, kaya nga triacyl kasi tatlong acyl, tatlong carboxylic acids ang nakukuha. Very good. Okay? So tandaan nyo to, magagamit natin siya sa pharmacology mamaya. Pharmacology of drugs. Moving forward, we have non-hydrolyzable lipids. Non-hydrolyzable lipids are the ones that are resistant to the hydrolytic power of lipoprotein lipase. Connected with our topic is the example cholesterol. Cholesterol is the dominant steroid in the body, dominant steroid in the body. And the reason why it is called as a steroid kasi meron siyang cyclic ring, four-cyclic ring structure code C-triple-P. I bet it's no longer new to you, so you can search in the Google what does C-triple-P nucleus mean. Okay, so yan yung dalawang classifications ng lipids. Again, your knowledge here will help you out in understanding latter discussions. So moving forward, since ang main concept on lipids is that they are insoluble to water, they are insoluble to water, anong kinalaman nito or anong relevance nito sa ating katawan? Okay? Ito yung i-gather nating thoughts right now. Again, since lipids are insoluble to water, anong relevance yan sa ating katawan? Since our body needs lipids, lipids have to be transported into different parts of the body. Okay? So, this have to be transported. Now, para ma-transport ang lipids, syempre, it has to be incorporated with the blood. Kailangan siyang sumama sa blood. Makinig dito ha, kasi we will establish the gap here. So, lipids have to be incorporated with the blood so that it will be circulated throughout our body for utilization. However, this is the problem. Okay? This is the sad thing about lipids. Remember, blood is aqueous. Okay? Blood is aqueous in nature. So this is rich in water. Okay? Rich in water siya. So with that being said, do you think would it be harder? Would it be harder for the blood to transport lipids considering that the blood is aqueous? Do you think there could be problem? Yes. So there could be a problem. Kasi ang dugo ay matubig siya, matubig. Pero ang lipid ay oily, kaya oily siya. So there will be separation. Okay? Kaya the blood will find it hard to transport lipids. So thankfully, we have an answer for that. So meron tayong sagot dun sa problema. Ang answer natin, again, ang solution natin for the lipids to be transported together with the blood is that it has to be combined with other biological molecules, and that is yung mga chons. Okay? They have to be combined with chons. What does chon mean? Ano yung mga chons? Ano yung mga chons? Yes, that's right. So they have to be combined with proteins. Remember, proteins have diverse roles. And one of the functions of proteins ay for transport. Okay? Isa sa function ng proteins ay for transport. Kaya for lipids to be transported with the blood and therefore be utilized in the different parts of the body, they have to be combined with proteins. That's why we have the term called lipoproteins. Okay? So basically, lipoproteins, this is the combination of lipids, and then we have the proteins. Specifically, what are the lipid components of lipoproteins? So number one, we have triacylglycerol. Of course, lipid component ito. Okay, again, lipid component siya. And then, second, we have cholesterol ester, a lipid component din siya. And then we have phospholipids, lipid component, apparently lipid component din siya. And then, free cholesterol, puro lipid components sila. Okay? So ito yung mga types ng lipids that are found in lipoproteins. Okay? Now, what about for the protein component? Don't forget this, everyone. Ang protein component sa lipoprotein ay tinatawag na mga apoprotein. Okay? Mga apoprotein. Often in books or in references, they have the symbol or abbreviation APO. So pag narinig niyo yung APO, anong ibig sabihin natin dyan? The protein portion of the lipoprotein. So far, do you understand me? Okay, very good. So focus tayo everyone sa apoprotein. Again, focus tayo sa apoprotein. Usually, ang apoprotein ay madedetect natin sa surface ng lipoprotein. Again, madedetect natin ito, makikita natin ito sa surface ng lipoprotein. For example, if you refer on the figure, yung apoprotein B100, makikita nyo sa surface. Okay? Ito yung color blue na hina-highlight natin right now. So that represents apoprotein. Okay? Responsible for certain roles in the body or in the blood. So in particular, i-specify natin ano ba ang kwenta or ano yung importance ng protein portion. Nabanggit ko na important siya for transport. Okay? Important siya for transport para maipamigay ang lipid sa mga parte ng katawan natin. Okay? What else? Important din ang apoprotein portion rather. Important din to for metabolism. Ay important to for metabolism because apoproteins serve as cofactors. Okay? They serve as cofactors in different enzyme reactions or enzymic reactions. Okay? So I repeat, we have transport, metabolism because they act as cofactors, and finally, they are also responsible for certain interaction, receptor interaction. Okay, receptor interaction. This is so because apoproteins can act as ligands as well. So they can bind to the receptors ultimately. Okay, again, transport, number one. Number two, metabolism because they act as cofactors. And then finally, receptor interaction because through the presence of apoprotein, these lipoproteins could bind to receptors. Okay, so they act as ligands. So altogether, this is the structure of lipoproteins. Guys, naintindihan ang importance ng term na lipoprotein, na gets ang importance ng protein addition to the lipids? Okay, very good. So with that being said, we can now proceed to the different types or groups of lipoproteins. So ang next slide na i-discuss natin, ano ang iba't ibang klase ng mga lipoproteins. By the way, for you to be clarified here, there are different types of lipoproteins depending on the protein composition and also depending on the lipid composition. I think this is no longer new to you kasi na-discuss natin ito briefly in biochemistry before. Okay? So we have 5 major groups. These are chylomicrons. Second, we have VLDL or very low density lipoproteins. Then IDL, low density lipoprotein, and finally HDL or high density lipoprotein. So let's discuss briefly the characteristics of each group kasi may relevance din ito sa drug actions and effects later. Okay? So first, mamaya madidiscuss natin yung bawat isa. Kaya doon na tayo sa una, we have chylomicrons. Take note that chylomicrons are the largest lipoproteins. Now, when we focus on the lipid composition of chylomicrons, amongst the 5 groups, ang chylomicrons ay largest and they contain mainly triglycerides. Okay? They contain mainly triglycerides and it accounts for 80 to 90% of the lipid component. And take note as well that chylomicrons originate from the exogenous dietary fat. In other words, chylomicrons are formed from the food that we eat. Ay galing siya sa pagkain na kinain natin. Kaya usually, nasisynthesize ang chylomicrons sa ating small intestine. Okay? Nag-originate siya o na-produce siya sa small intestine natin. Don't forget this because may figure tayo that will explain this process later. Okay? And then we discuss na transport of dietary lipids kasi nga this can be obtained from the food that we eat. Okay? So yan ang chylomicrons. Next, pwede na po sa very low. Okay, next, let's proceed to very low density lipoproteins. Take note guys, ang characteristics ng VLDL at chylomicrons ay almost similar. Okay, almost similar. Bakit sila almost similar? Number one, just like chylomicrons, ang very low density lipoprotein, ang major lipid composition niya, triglycerides din. Okay? Triglycerides din ang major lipid composition niya. Yun yung unang major similarity. Okay? Yun yung major similarity. And then, For very low density lipoproteins, ito yung konting difference compared doon sa chylomicrons. Number one, endogenous ang VLDL. Okay, endogenous siya. Unlike ng chylomicrons, what did I tell you? Ang chylomicrons ay exo. Okay, exogenous siya. Why exogenous? Because ang chylomicrons ay nag-originate sa small intestine kasi galing nga iyon sa pagkain kinain natin, yung lipid composition niya. Okay? Now, sa case ng VLDL, the reason why this is called as endogenously derived lipoprotein kasi sa loob siya galing. Okay? Sa loob. Particularly, these are being synthesized by the liver. Okay? This is being synthesized by the liver. That's why it's indicated that ang very low density lipoprotein ay eventually sinesecrete ng liver. Do you understand? Gets? Okay, so yun yung similarity at differences. Please observe the similarity and differences kasi magagamit din natin siya mamaya. Okay? So moving forward, we have the intermediate density lipoproteins. Intermediate density lipoproteins are also known as VLDL remnants. Okay? So ang tawag natin dito ay VLDL remnants. Pag sinabing remnants in Tagalog, tira-tira. Okay? So 'di ba ibig sabihin ng remnants tira-tira. So yung tira-tirang portion ng VLDL ay tinatawag na IDL. Now, ano naman ang characteristics ng intermediate density lipoproteins? The term is remnants kasi ang IDL ay derivative ng VLDL comprising of lesser amount of triglycerides, a lesser amount of triglycerides compared to VLDL. When you remember, if you could still remember, ang VLDL mayaman sa triglycerides. Etong IDL nabawasan ang triglycerides. Okay? So bawas ang triglyceride portion niya. Kaya remnants ang tawag. So quantitatively, the average triglyceride content is 40%, ay 40%, unlike ng VLDL, it's almost 70%, right? And then ang cholesterol content is 30%. So that's for intermediate density lipoproteins. Next, let's have low density lipoproteins. Number one, for low density, again, LDL na tayo klasa. I hope you can still follow me. Regarding LDL, number one, this is devoid of triglycerides. Okay, so wala na siyang triglycerides. In fact, ang lipid component lang ng LDL ay cholesterol. Okay, cholesterol. So I repeat, low density lipoproteins, these are the ones that contain primarily cholesterol as the lipid component. Now, ang LDL, ay ang low density lipoprotein, this is the type of lipoprotein that carries cholesterol, from the liver going to the smooth muscles, or peripheral tissues. I repeat that LDL is the one that carries cholesterol coming from the liver going to peripheral tissues and also smooth muscles. Okay? So yan ang LDL. So for LDL, this is also known as, based on your stock knowledge, bad or good cholesterol. Okay, good. So we have, good yung answer nyo. Tama yung answer nyo. So ang tawag dito ay bad cholesterol. So mamaya marirealize nyo ulit bakit siya bad cholesterol. Okay? At ang palatandaan pa sa LDL, I think naturo ko to before, try to imagine that yourselves are the ones studying and kayo ang liver. So you always tell na kapag LDL, kung kayo ang liver, layo cholesterol, layo cholesterol, layo cholesterol. So kung ikaw ay liver at layo cholesterol, LDL yon. Okay? palayo siya ng liver at papunta sa mga peripheral tissues. So later, I will explain bakit siya bad. Ay, bakit siya bad. So this is the product. Let's continue. LDL is the product of intravascular metabolism of triglyceride-rich lipoprotein VLDL. So remnants din siya ng VLDL pero devoid na siya ng triglycerides. Okay? And then catabolized chiefly in hepatocytes and other cells by receptor-mediated endocytosis. This will be discussed later. And as I've said, primarily cholesterol ang content niya. Okay? So far, natapos natin 4 groups na. And to conclude the groups of lipoproteins, we have high-density lipoproteins. Take note, ang complete opposite ng HDL ay ang LDL. Okay? Unahin natin ang similarity nila. Ang similarity ng LDL at HDL, parehas sila nagdadala ng cholesterol. Okay? Parehas sila nagdadala ng cholesterol. Now, ang pinakaiba lang nila is that since ito ay HDL, isipin nyo, as the liver, halika cholesterol. Okay? Halika cholesterol. So kung halika cholesterol, what would be your inference here? Saan palapit ang cholesterol? Sa tissues or sa liver? Okay, very good, sa liver. Kaya kapag high-density lipoprotein, ang travel ng cholesterol ay from peripheral tissues going to the liver. Okay, peripheral tissues going to the liver. So tandaan, yan ang process or function ng high-density lipoprotein. So it carries cholesterol from the peripheral tissues or smooth muscles going back to the liver. That's why ang tawag sa kanya ay good cholesterol. So ang tawag sa kanya ay good cholesterol. Mamaya, madidiscuss ulit natin bakit siya good at bakit siya bad. Okay, yung sa LDL kanina. So overall, that concludes our discussion on the 5 groups of lipoproteins. Naintindihan po yung 5 groups of lipoproteins? Okay, so this slide only shows the difference between HDL as the good cholesterol and LDL as the bad cholesterol. I repeat, this will make sense mamaya kapag na-discuss na natin ng elaborate yung physiology of handling lipids. Okay? So just to check if you could still follow me, please answer what is being asked. So meron akong ide-describe na lipoprotein. Tell me kung ano ang sagot. Pwedeng abbreviation lang, pwedeng initials lang, completely understood na siya. Are you ready? Are you ready, everyone? Okay, good. So, number one, originates from the small intestine. Very good, chylomicron. Next, main content, triglyceride, comes from the liver. Yes, that's right. VLDL. Next, what are the lipoproteins? What are the lipoproteins containing primarily triglycerides? Contain primarily triglycerides. So dalawa sila. Very good. We have chylomicrons and VLDL. Sino ang endo sa dalawa? Okay, very good. Next, good cholesterol. Bad cholesterol. Away from the peripheral tissues. Kabisote, pakinggan niyo yung sinabi ni Sir. Away from the peripheral tissues. So what's your conclusion there? Palapit ng liver yon, di ba? Kasi palayo ng peripheral tissues eh. So what's your answer? Yes, that's right. HDL. Next, bad cholesterol. Very good. Next, what are the lipoproteins devoid of triglycerides? R. In other words, ano lang yung merong cholesterol? Yes, very good. LDL and HDL. Naintindihan na po so far? Okay, so pwede na tayo mag-continue sa slide na to. Okay, so let's continue. So please pay attention in this figure. And I guess, hindi na to bago sa inyo kasi na-discuss natin ito sa biochem dati. O i-recall lang natin para maalala nyo. Okay? So in this figure, we will discuss the physiology of handling lipids. Again, yung mga knowledge na nakuha nyo sa previous discussions ko, ma-apply natin dito. Okay? Number one, please recognize first the shading of the figure, yung color shading niya. You can see that on the left side, we have exogenous pathway. Yung color beige ata yan, exogenous pathway. And then yung medyo malapit sa blue-green, we have endogenous. Pag exogenous, ibig sabihin, ito ay nag-o-originate from the food that we eat, ay sa pagkain na kinain natin, and then endogenous sa loob na ng katawan. So please recognize the two sides. So we have exogenous and then endogenous. Aside from that, kindly recognize different organs responsible. So number one, I want you to recognize the small intestine. May importance ba ang small intestine sa mga lipids na dinidiscuss natin kanina? Yes, meron. So I hope meron kayo maiko-connect dyan mamaya. And then, of course, liver, very versatile organ. So maidi-discuss din natin siya. And then, extrahepatic, meaning to say, peripheral tissues. Halimbawa, mga smooth muscles. Okay? And then, take note, we have capillaries. We have capillaries containing the blood. Okay, containing the blood. Now, sa capillaries, tandaan, meron tayong enzyme na makikita called lipoprotein lipase. So meron tayong enzymes na makikita called lipoprotein lipase. Meron bang relevance ang lipoprotein lipase sa fate ng lipids? Sa journey ng lipids? Yes, meron. So I hope na re-retrieve niyo yun lahat pag sasama-samahin natin sila dito. So are you ready? Start na natin i-discuss. Okay, so unahin natin ang exogenous pathway. Suppose kumain tayo ng lechon, kumain tayo ng burger, kumain tayo ng ano pa bang masasarap na pagkain. So halimbawa kumain tayo, and of course, digestive system would basically digest the food that we eat until such time that i-extract ng ating small intestine ang iba't ibang mga nutrients na nakuha from the food. And one of them are the lipids. Of course, kapag ang lipids ay nakarating sa small intestine, these lipids that came from the dietary food that we eat contains triglycerides and also cholesterol. Okay? So meron siyang triglyceride and also cholesterol. Now, kapag present na sa small intestine ang triglycerides and cholesterol, ready na sila for absorption. Okay, ready na sila for absorption. Kaya lang, anong problema natin? 'Di ba pag i-absorb ang lipids, ibig sabihin sasama siya sa blood. Yun nga ang problema. Since lipids are immiscible with the blood, challenging ito. Kaya thankfully, meron tayo mga apoproteins. Naalala niyo yung apoproteins? Sila yung protein na didikit sa lipids. So, magko-combine ang apoproteins and also lipids. Kaya finally, makakabuo tayo ng lipoprotein. Kaya finally, makakabuo tayo ng lipoprotein because this is the combination of the lipids from the food and also apoprotein. And ang tawag natin sa unang lipoprotein na nagagawa ay chylomicrons. Kaya anong descriptions natin sa chylomicrons? Tama ba kung exogenous ang chylomicrons? Okay, and then saan nag-originate ang chylomicrons? Intestine. Okay, intestine. So let's continue. Very good, small intestine. So let's continue. Once absorbed ang chylomicrons, ready na siya for different transport or transportation process and also metabolism as well as, let's say, receptor interaction. So habang nagta-travel ang chylomicrons, of course, in the capillaries, it will meet an enzyme. So it will meet lipoprotein lipase that is a hydrolyzable lipid. Okay, hydrolyzable lipid. Now, anong implication? Pag nagkita, again, anong implication pag nagkita ang chylomicron at ang lipoprotein lipase? This tells us that lipase will hydrolyze chylomicrons, particularly the lipid na hydrolyzable sa kanya. Okay? Recall, sa structure ng chylomicrons, Anong lipid ang susceptible sa lipase? Is it triglyceride or cholesterol portion? Yes, very good. We have triglycerides. That's why ang triglyceride ay matatapyas, okay, ma-cleave siya from the chylomicron. Ano nga ulit ang product pag na-hydrolyze ang triglycerides? Yes, that's right. Kaya meron dito free fatty acids. Free fatty acids would be taken up by the adipose tissues as well as muscle for energy reserve and in some instances for energy utilization. Okay? Kaya na-cleave na ang triglyceride portion. So with this being said, ano ang ating realization? Kapag na-hydrolyze ang triglyceride portion, ang chylomicron bababa ang triglyceride portion niya. Bababa ang triglyceride content niya. Na-gets ba't bumaba ang triglyceride composition niya? Okay, so bumaba ang triglyceride. So ang tawag natin kapag nabawasan ang chylomicrons ay chylomicron remnants. Okay? Chylomicron remnants sa ang tawag doon. If you will check the size of chylomicrons and the remnants themselves, mas maliit ang size ng remnants. Kasi nga, tinanggal ang triglyceride portion. Okay? So what happens next? Okay, doon tayo sa next step. Remember, kapag ang chylomicron remnants ay nabuo, kailangan siyang pumunta sa liver. So it will be uptaken by the liver. No problem with this. The remnants could enter the liver through receptor endocytosis, okay? Through receptor-mediated endocytosis. So the remnants could interact with the receptor found in the liver. Question, what's the reason ba't siya kaya mag-interact sa receptor? Kasi anong composition meron ang chylomicron remnants? Meron siyang yung lipid portion o yung protein portion? Okay, yung apoprotein portion niya. Kaya endocytosis could happen. That's why remnants will enter the liver. So at the end of exogenous pathway, papasok din ultimately yung remnants sa liver. So sa dulo so far, nasa liver na ang remnants. Can you follow me? Can you still follow me? Okay, so let's continue. Once the chylomicron remnants are found in the liver is a versatile organ. One of the functions of the liver related to lipid handling is that it can transform the remnants. In Tagalog, isang kakayahan ng liver is idagdag yung nawala kanina sa chylomicrons. Ano yung nawala sa chylomicrons kanina? Ang nawala, triglycerides, tama? So in other words, ang liver, it can repack the remnants by adding triglycerides. So dinadagdagan ng liver ng triglycerides yung remnants. Kaya dadami na naman ang triglyceride component nung remnants. Okay? And when the time comes na reach na ulit sa triglycerides, yung remnants, ready na siyang ilabas ng liver ulit. Okay? Ready na siyang ilabas ng liver ulit. And release of this transformed remnants, ang tawag na doon, everyone, again, ang tawag na doon ay VLDL. Okay? Ang tawag na doon ay VLDL. So I hope na alala ang information about VLDL. Number one, reach ba sa triglycerides ang VLDL as we remember? Yes, very good. So ngayon, nasagot nyo na kung bakit. Kasi sino nag-feel nung nawala kanina? The liver ang nag-feel. Okay, yung liver. Next, anong sabi ko kanina? Nag-o-originate saan ang VLDL? Sa liver. So it really makes sense. And then, what did I tell you? Ang VLDL ay exo or endo? Endo. So makikita nyo nasa side siya ng endogenous. Na-relate po ba yung description sa lipoproteins dito sa discussion? Okay, so let's continue. So you can see that ang VLDL, it's now rich in triglycerides. Okay? pero not as much compared sa chylomicrons, but still marami. Okay? And then the cycle continues, ita-transport ulit ang VLDL, and then mamimit na naman niya ang enzyme na lipase, kaya ang triglycerides makikleave off ulit. Cleaving off of triglycerides or hydrolysis of triglycerides results in free fatty acid formation, which now be ready for tissue utilization. Kaya you can see that in the figure, lumiliit ang size ng VLDL. Now, pag lumiit siya, remnants na lang ang matitira. Ang tawag natin sa remnants ng VLDL ay IDL. Nabanggit ba ni teacher na remnants ng VLDL ang IDL kanina? Okay, so yun yun. Yun yung remnants. We have intermediate density lipoprotein. Ang intermediate density lipoprotein, meron siyang triglyceride composition pa rin, pero significantly bumaba na siya. Okay, bumaba na siya. And then cholesterol, meron ding cholesterol contents but unchanged. Question, bakit unchanged? Kasi ang cholesterol, even if it saw or nakita niya ang lipase, resistant siya sa hydrolysis. Okay? Even nagkita sila ng lipase, resistant siya sa hydrolytic power nun. So continue natin. And then, meron na namang lipoprotein lipase until such time na ang triglyceride component ng lipoprotein naubos na. Okay, naubos. Pag naubos yon, ang tawag natin sa cholesterol-containing lipoprotein ay LDL na. Okay? Low density lipoprotein. That's why I told you ang LDL devoid of triglycerides. Wala siyang triglycerides. Okay? Or very insignificant. Kasi ito yung huling produkto pag tinira na ng tinira ng lipase yung lipoproteins. Naubos na niya yung triglyceride portion. So yun na yung LDL. Okay? Now, focus tayo sa LDL. Anong sabi ko sa LDL? Ano ang journey ng cholesterol through LDL? Palayo o palapit ng tissues? Palayo or palapit ng tissues? Ha? That's right. So palapit ng tissues kapag LDL. That's why makikita natin ang LDL, it can now reach the different extrahepatic tissues via LDL receptors. No problem kasi meron siyang apoprotein B100. Okay? It has apoprotein B100 that can interact with the receptors causing endocytosis. Okay? Causing endocytosis. Kaya makakapasok na ang cholesterol in the extrahepatic tissues. And in the extrahepatic tissues, may mga functions ang cholesterol na dala-dala ng LDL. So mamaya mag-discuss natin yon. Okay? So yan ang function ng LDL. And then finally, ang HDL, mamaya i-explain ko bakit kailangan ng HDL. Okay? Madidiscuss natin siya mamaya. But basically, tandaan nyo, ang HDL, it carries cholesterol pero pabalik na eventually sa liver. Okay? Pabalik na siya sa liver. Nag-iiba ang direction ng cholesterol via HDL kasi kung titignan nyo sa notes, yung apoprotein component niya compared sa LDL, iba. Okay, iba. So pag naiba ang apoprotein component, nag-iiba ang direksyon ng lipid na kinikerry. Okay, yung lipid na kinikerry. So that's why magkaiba ang direksyon ng HDL at LDL. Okay? So this is the figure explaining how the body handles lipids. So para ma-reinforce pa yan lalo, isa pang discussion or figure explaining that, we have this. O ganun din yan na iba lang ng itsura. Okay? So halimbawa, we have, check nyo na lang ha, we have intestine, and then chylomicrons na galing nga sa intestine, and then lipoprotein lipase. So ang lipoprotein lipase, kukunin ang fatty acid composition na gagamitin ng tissues and adipose, and then remnants. Ang remnants, ano ang fate ng remnants? Pupunta ba sa liver ang remnants? Yung chylomicron remnants. Yes, so pupunta siya sa liver, kaya nandito siya. And then what will the liver do? I-make over niya. Okay, i-make over niya yung remnants at magiging VLDL na siya. Kaya may VLDL kayo makikita rito. And then lipoprotein lipase na naman, may derivative na namang free fatty acid, and then IDL, and then LDL. Okay? LDL. And then ang LDL, dadalhin ang cholesterol sa peripheral tissues at meron nga siyang importance na may didiscuss natin mamaya. Naintindihan? Okay, very good. So on the final figure related to physiology of handling lipids, I want everyone to focus on LDL. So focus tayo kay LDL. Kasi yung mga nandito, madidiscuss natin dito or madidiscuss natin ito later. Okay, madidiscuss natin later. Lalo na yung naka-yellow, madidiscuss natin siya later. Okay? Pero yung ibang portions, na-discuss na siya. Pero dito sa LDL, yung specific fates ng LDL, hindi pa natin na-discuss so far. So right now, let's explain the fates of LDL. Recall that LDL is the one that carries cholesterol. So it carries cholesterol to peripheral tissues. Mind you na isa lang yon sa mga fates ng LDL o sa ginagawa ng LDL. Okay? So explain natin kung ano nangyayari sa peripheral tissues. So, ito yon, number 1. Number 1, okay, first fate. Pag ang LDL ay nagawa na, containing cholesterol, the first fate of LDL is that it goes to the peripheral tissues or peripheral cells. Di ba nasabi ko yan sa inyo kanina? This is because LDL binds to the LDL receptor causing endocytosis. Causing endocytosis. Kaya papasok ang cholesterol sa loob ng ating peripheral cells. Now, what's the importance of cholesterol inside our cells? Ang daming importance yan. Ang daming importance. So in connection to that, yung slide na ito, pakihanap na lang sa notes nyo ha. Yung slide na ito yung unang fate ng cholesterol sa loob ng cell natin. So ang importance ng cholesterol is that it serves as the precursor or raw material in the production of different compounds in the body. Particularly, ang cholesterol ay ating raw material para makagawa ng testosterone, estradiol, which are sex hormones. Important siya. And then, important din ang cholesterol for cortisol and aldosterone production, which are corticotropic hormones. And also, we have vitamin D, important din siya. And in the cell membrane, it provides stability of the cell membrane. So, it provides stability of the cell membrane. And then finally, ang cholesterol ay ang raw material for bile acid production. Okay? For bile acid production. I repeat, ang importance ng cholesterol kung bakit siya dapat makapasok ng cell are these ones. Okay? Synthesis of hormones, synthesis of vitamins, and then stability of the cell membrane and bile acid synthesis or bile salt formation. So that represents the first fate or destiny of cholesterol. Nakita ba yung slide na to sa notes nyo, guys? May minodify lang ako sa sequence pero nandyan yun. Okay, so tapos na tayo sa first fate. So important ang cholesterol sa cell kasi gumagawa or ginagamit siya para gumawa tayo ng iba't ibang mga substances. Okay, kaya may nakaturo dyan, steroids, yung mga steroidal hormones, sex hormones, corticotropic hormones, and then stability ng cell membrane. So yan ang unang fate. Ayan yung unang fate. Next, pangalawang fate. Pwede na po sa pangalawang fate. Okay. Pangalawang fate, we have this one. Okay. Pangalawang fate, we have this one. And this does not normally happen. This does not normally happen. This usually happens kapag ang LDL ay marami na, okay? Kapag may excess tayong LDL. So for example, if we have too much LDL and hindi na siya ma-accommodate ng mga cells natin, syempre, may mga palaboy-laboy sa blood. And ang implication nun or the consequence of excess LDL, marami din tayong cholesterol na palaboy-laboy sa katawan. Okay? Dadami rin ang cholesterol na freely circulating in the body. Now, kapag freely circulating siya sa katawan natin, chances are, this excess LDL could deposit, okay, could deposit in the intima of the arteries. Okay, so pwede silang ma-deposit sa intima ng arteries. So intima are arterial walls, okay? Yung wall ng artery. So pwede silang mapunta sa intima of the arteries. So what could happen if naging existent na or naging evident na ang mga excess LDL sa arteries natin? This could be detected by macrophages. Okay? This could be detected by the macrophages. So ang tendency, this macrophage, di ba ang mga macrophages, they are phagocytes. Okay? They are phagocytes. So in short, they will phagocytose, in Tagalog, kakainin ng mga macrophages yung mga excess cholesterol. So kakainin nila, i-engulf nila, kakainin. So what could happen pag kinain? Papasok ngayon ang mga fats, halimbawa itong sinishadean ko ng red, yung mga fats or excess LDL, and therefore macrophages would be lipid laden. Magiging rich in fats siya. Usually, kapag ang macrophage ay rich in fat, it will undergo apoptosis. Okay? It will undergo apoptosis. So what is meant by apoptosis? That is cell death, di ba? Magpo-promote ng cell death. Magpapakamatay macrophage kasi ang taba-taba na niya. Okay? Dahil rich siya in fats, rich siya in lipids, particularly cholesterol, magpapakamatay siya. Ngayon ang problema, pag namatay ang macrophage at nasa artery siya, yung mga dead macrophage sa arteries, tumitigas sila. Okay? Tumitigas. So ang tendency, pag namatay ang macrophage at tumigas sila sa arteries, ang arteries mo tumitigas din. Okay? Tumitigas din yung arteries. Kaya nagkakaroon ka ng atherosclerotic plaque. Okay? Nagkakaroon ka ng atherosclerosis or tumitigas yung wall ng arteries mo. Everyone, na-gets? Naintindihan ako? Okay. So very good. I hope naintindihan. So pag mataba ang macrophage, mag-apoptosis siya. Kaya yung namatay na macrophage na rich in lipids, ang tendency, ano nangyayari? Tumitigas din ang arteries. Okay? Before I forgot, ang tawag doon ay now oxidize siya. Okay? Oxidation of LDL in the macrophages. Okay? There is oxidation. So anong implication niyan lahat? I have a question. May health consequence ba yung nangyari na excess LDL? Yes, okay, meron siyang health implication. Ano ang health implication niya? Natutunan nyo sa cardiovascular drugs na ang arteries, they have to be elastic when there are changing pressures. Di ba kailangan mag-expand siya, mag-constrict siya depending on the pressure to facilitate distribution of oxygenated blood. So try to imagine kapag tumigas ang arterial wall natin, ang arteries, it cannot cope up in changing environments. Hindi siya makapag-cope up. Kaya ang ultimate effect nito is yung dami ng oxygen na pinamimigay sa mga tissues, tumataas or bumababa. Ano nangyayari? That is, ano nangyayari sa level ng oxygen? Very good, bumababa ang oxygen na nadidistribute sa iba't ibang tissues in the body. Okay? Ito yung tinatawag na barado ang ugat. Okay? Barado ang ugat. So yun yung nangyayari kapag may excess LDL tayo. Kasi pwede siya ma-deposit sa arteries, tumitigas kasi kinakain siya ng macrophage at nagpapakamatay. Kaya di ba natutunan nyo sa angina, isang cause ng pagsikip ng dibdib ay atherosclerosis. So yan ang discussion natin on the fate of LDL. So balikan natin ang fate ng LDL. Number one, yung normal, we have endocytosis for tissue utilization. And then number two, we have pag-excess na siya. Kaya overall, anong tawag natin kay LDL? Ang tawag natin sa kanya ay bad cholesterol. Kaya ang tawag natin sa kanya ay bad cholesterol. Nagets bakit siya bad? Okay, very good. So yan ang fate ng LDL. So mamaya, madidiscuss natin ang HDL naman. Okay? So next. So moving on, continue natin. Pwede na ba? So let's continue. After we discuss the fates of excess LDL, so na-discuss natin, pwede siya ma-oxidize, causing atherosclerosis. So let's now move on to the liver itself. Meron tayong dapat i-discuss about the liver related to lipid handling. And this has something to do with the two major functions of the liver on how it handles lipids. Okay? Number one, the liver is important because it repacks triglycerides into VLDL. So the first role of the liver in lipid handling is that it repacks triglycerides into VLDL. Everyone, naalala nyo ba yung repacking of triglycerides into VLDL? Naalala nyo to kanina? Yes, okay. So 'di ba, kinukuha niya yung remnants ng chylomicrons, idadagdag niya yung triglycerides, so nagiging VLDL. That's nice. So that's the first role of the liver. Second, ang second role ng liver naman is it synthesizes the compound called bile acid. Again, the second role of the liver is it synthesizes bile acid. So in this case, let's talk about bile acids. Okay? Ang bile acid ay important sa katawan natin and the organ that produces bile acid is the liver. Now, ano ba ang raw material or saan galing ang bile acids? Ang raw material in the production of bile acids ay, anong sabi natin kanina, saan galing ang bile acid na compound? Saan galing? Okay, very good. Galing ang bile acid sa cholesterol. Okay, galing sa cholesterol. Now, in this case, I have something to emphasize, pero siguro familiar na kayo dito kasi you have kinetics right now. So remember that bile acids, they came from or they are derived from cholesterol. However, the liver does not usually synthesize too much bile acids. Are you familiar with that? So ang liver hindi siya basta-basta gumagawa ng maraming bile acids kasi sa ginagawa na bile acid ng liver, out of 100% initial production, only 90 to 95% are being reabsorbed. Ay 90 to 95% are being reabsorbed, meaning bumabalik siya ulit sa systemic circulation, or not really in the systemic circulation, but rather bumabalik sa liver and stored in the gallbladder. And only approximately 5% ang na-excrete. Okay? Only approximately 5% ang na-excrete via stool or feces. Okay? So out of 100%, 90 to 95% ang nare-reabsorb, and then approximately 5% ang na-excrete in the feces. And focusing on 90 to 95% reabsorption, the mechanism of reabsorption is called biliary recycling. Familiar na kayo dito? Tama ba ako? Or nakalimutan na? Familiar? Honest to goodness, nare-recall ang biliary recycling? Okay, that's good. So 90 to 95% of bile acids ay nare-reabsorb via biliary recycling, or this is also known as enterohepatic recirculation. Okay, this is also known as enterohepatic recirculation. So that is also known as enterohepatic recirculation. So in connection to that, let's explain this figure. Okay, let's explain this figure. This is the mechanism of biliary recycling in the body. Okay, so ito yung process called biliary recycling. Refresh lang tayo. Sir, anong sense ng mga sinasabi mo? Bakit wala ka pang gamot na dinidiscuss, sir? Lahat ng dinidiscuss kong concepts ay applicable sa drugs mamaya. Makikita nyo mamaya yung importance ng lahat ng sinasabi ko. Kasi yung mga processes na dinidiscuss natin at this point, ito yung mga imo-modify ng medications mamaya. Okay? Are you still there? Ready na sa biliary recycling, guys? Okay, very good. So remember, in biliary recycling, this is the mechanism of reabsorption, a reabsorption of bile salts or bile acids by our body. So paano siya nangyayari? Umpisahan natin syempre sa synthesis para hindi kayo malito. Remember na ang ating raw material, tingin sa PowerPoint ha, tingin sa PowerPoint, ang ating raw material to produce bile acid ay cholesterol. And then after synthesis by the liver, mapoproduce ang bile acid or bile salts. So what happens? Usually, ang bile salts ay i-excrete. Again, makinig, i-excrete siya. So ma-excrete siya via this process. Ang bile salt coming from the liver will pass through the common bile duct, okay? Common bile duct, until such time that it reaches the small intestine. Hanggang nasa small intestine na siya. So focus on the pink highlighter, okay? So we have the bile acid found in the small intestine. Now, out of 100%, again, out of 100%, only approximately 5% ang napupunta sa colon natin. Okay? Only approximately 5% ang napupunta sa colon. Ang colon ay large intestine. So anong conclusion? Pag nakarating sa colon, yung portion ng bile salt na to, maidudumi na ba siya? Mailalabas na ba siya? Yes, that's why I told you 5% is being excreted via the colon or in the form of stool or feces. So yan yung 5%. Now, paano naman yung remaining 90 to 95%? Yung remaining 90 to 95%, take note, remaining 90 to 95% ay pumapasok sa tinatawag na hepatic portal vein. Dumadaan siya sa hepatic portal vein. So when we say dadaan sa hepatic portal vein, again, pag sinabing pupunta sa hepatic portal vein, pag dumaan ang bile acid sa hepatic portal vein, bumabalik siya sa liver. Okay, bumabalik siya. Kaya anong sabi natin? 90 to 95% ay nare-reabsorb. Ang tawag natin sa mechanism ng pagdaan sa hepatic portal vein ay biliary recycling. Kaya nga recycle, imbes na tinapon, gagamitin ulit. Okay, gagamitin ulit. So far, can you follow? Ha? Okay. And then kapag, makinig kapag nakabalik na yung 95% bile salt sa liver, finally, i-store na siya saan? Sa gallbladder. Okay? I-store na siya sa gallbladder. So with this taken all together, ano ang mga strong points to consider? Number one, makinig Number one, out of 100%, 5% lang ang tinatapon. Kaya therefore, I have a question. Kumusta ang dami ng bile acid na ginagawa ng liver per round? Marami o konti ang ginagawa niya per round? Per cycle of bile acid synthesis? Konti lang. Very good, konti lang. 5% lang ang gagawin niya kasi yung 95% bumalik naman eh. Kaya normally the liver produces less bile salt kasi nai-store lang din naman yung majority sa gallbladder. Okay? So that's what we mean by biliary recycling. Naintindihan? Ha? Okay, so let's check if naintindihan nyo talaga. Magbibigay ako ng situation about biliary recycling ha. Magbibigay ako ng situation. What if you encountered a drug? Kasi may gamot tayo madidiscuss mamaya about related to biliary recycling. What if a drug blocks biliary recycling? Okay, so kapag binlock nung gamot ang biliary recycling, anong ma-i-infer nyo? Anong mako-conclude nyo? Ano ang kayang pababain ng gamot sa katawan natin? Ha? Anong kayang pababain ng gamot? So pag na-block niya ang hepatic portal, hepatic recirculation or biliary recycling, question, marami bang itatapon na bile acid ang katawan? Marami bang itatapon na bile acid ang katawan? Yes, very good. Question, saan made up ang bile acid? Saan made up ang bile acid? Saan siya gawa? I mean, hindi organ saang material? Very good, cholesterol. So, kapag nagtatapon ka ng maraming bile acid, nagtatapon ka ba ng maraming cholesterol? Yes. So kapag may gamot na nag-block ng biliary recycling, anong marirealize nyo? Okay, yung gamot na yan nagpapababa ng cholesterol sa katawan. Did you get my point? Okay. So ano pa? Yun yung connection ng mga drugs. So ano pa? Actually, may side effect din kayo ma-observe dito. 'Di ba? Nagtatapon tayo ng bile acid made up of cholesterol. Kaya na-expect mo na kapag nagtatapon ka ng cholesterol sa stool, makikita mo na ang stool mo ay fatty siya, fatty. So related 'yon dito. Okay? So madidiscuss natin yung specific drugs later. Overall, did you get the second function of the liver, yung synthesis of bile acid? Okay na 'to? Okay, so very good. So bago tayo mag-proceed sa mismong condition called dyslipidemia, meron pa akong isang concept na i-discuss related to drugs. So right now, let's discuss the sources of cholesterol, sources of cholesterol for bile acid synthesis. So another important topic to discuss about physiology, we have sources of cholesterol for bile acid synthesis. Recall that the liver needs cholesterol for it to produce bile acid. Now, meron tayong iba't ibang sources ng cholesterol by the liver para makagawa siya ng bile acid. Take note ha, makinig, it does not include the food that we eat. Yung mismong loob lang ng liver, yung ating pagbibigyan ng focus. So number one, the first way of the liver is called the primary source. So ang tawag natin sa primary source is the de novo cholesterol biosynthesis. Again, that is called the de novo cholesterol biosynthesis. When we say de novo, that means sariling sikap ang liver in producing cholesterol. Sariling tiyaga siya in producing cholesterol. So in this case, meron tayong mga important points to remember. Number one, ang site of de novo cholesterol synthesis, syempre sa ating atay, sa ating liver. So site is in the liver. And take note, it peaks at night. Okay? Tuwing gabi, gumagawa ng cholesterol ang liver. So it really peaks at night. So sa gabi siya gumagawa. And this is how it goes. Doon tayo sa mga important steps. Okay? So number one, ang kailangan ng liver, ay acetyl-CoA muna, ay acetyl-CoA. Saan ba galing ang acetyl-CoA? Sa kinakain din natin pagkain, di ba? Halimbawa, proteins, carbohydrates, lipids. Kaya biochem is important here. Okay? So ang acetyl-CoA, isang fate ng acetyl-CoA ay cholesterologenesis. And that is yung de novo cholesterol biosynthesis. And that is via the enzyme HMG-CoA synthase, via the enzyme HMG-CoA synthase that causes formation of HMG-CoA, that causes formation of HMG-CoA. And then, via the action of HMG-CoA reductase, via the action of HMG-CoA reductase that causes formation of mevalonate or mevalonic acid. So I repeat, via HMG-CoA reductase, there is reduction of HMG-CoA forming mevalonic acid. Take note that this catalytic reaction is the first committed step, meaning kapag nangyari ito, sunod-sunod na ang mga events that will happen, sunod-sunod na yung mga events that will happen para makabuo ang liver finally ng cholesterol. Okay? So that causes succeeding or that results to succeeding processes that would eventually lead to cholesterol production. So that is the primary source of the liver para makabuo siya ng cholesterol. Now, makinig, kapag nabuo ang cholesterol, edi ready na siyang gawing bile acids. Kaya nga ang topic na dinidiscuss natin ay ano ang mga pinagmumula ng cholesterol na gagamitin ng liver to produce bile acid. So that's the first source. Gets? Nagets ba ako? Familiar to sa inyo. Tama ba ako? Familiar sa inyo yung step na to? Or not so much? Okay, so proceed tayo sa number 2. We have alternative sources. Okay, number 2, we have alternative sources. What is meant by alternative? Pag sinabi nating alternative, kapag hindi enough ang primary source, gagamitin ng liver ang alternative sources. Kaya nga siya alternative pag hindi sapat yung una. Okay? So magandang bagay sa liver natin, gumagawa talaga siya ng paraan para magkaroon siya ng cholesterol. Hindi siya papayag na mawalan siya. Kaya meron siyang parang pansalo. Okay, pansalo. So dito tayo sa alternative sources. Number 1, isang paraan ng liver paramihin ang HDL. Okay, again, isa pang paraan ng liver pag hindi enough ang de novo, that is to enhance HDL production. Question, makinig sa akin ha, anong relevance ng pagpapadami ng HDL by the liver? Anong implikasyon niyan? Makakatulong yung diniscuss ko kanina about this concept. Guys, kung babalikan ng HDL, ano ang ginagawa ng HDL? Anong dala-dala niyang lipid? Answer me. Anong dala-dala niyang lipid? That's right. Kole ang dala niya. Paano niya dinadala ang kole? Palapit o palayo ng liver? Very good. So ang dala-dala, nasa na tayo? Ayan. So ang dala-dala ng HDL ay cholesterol papuntang liver. So when the time comes na dumami ang HDL sa katawan natin, maraming madadalang cholesterol sa liver. Pag maraming natanggap na cholesterol ang liver tiyak gagamitin na siya para makagawa ng bile acid. Kaya isang paraan yan ng liver. O di ba ang galing? Naisip ng liver yon na parami ng HDL. Kaya magkakaroon tayo ng cholesterol source at makagagawa siya ng bile acid. Are you learning? Do you understand this? Okay, good. So, proceed tayo sa second alternative source. Sa second alternative source, ang ginagawa naman ng liver ay pinaparami niya ang expression ng hepatic LDL receptors. Again, pinaparami niya ang expression ng hepatic LDL receptors. Ano pong ibig sabihin ng hepatic LDL receptor? Pag sinabing hepatic, sa liver syempre. Okay, sa liver. In other words, pinaparami ng liver ang receptor niya for LDL. Okay? Pinaparami niya ang receptor niya for LDL. So halimbawa, hindi ako marunong mag-drawing. So halimbawa, ito na lang yung liver. Yung box halimbawa, yung liver. And then, yung dinrawing ko, ito yung LDL receptors. So for instance, hepatocyte ito, a hepatocyte. And then we have the hepatic LDL receptors. So sabi natin sa second alternative source by the liver, pinaparami niya ang expression ng hepatic LDL receptor. What is the implication there? Ibig sabihin yan, pag marami tayong hepatic LDL receptors, it is expected na na-enhance natin ang ligand receptor interaction. Okay, na-enhance natin ang ligand receptor interaction. Now, anong ligand ang pinag-uusapan natin dito? Ang pinag-uusapan nating ligand ay ang LDL. Ay ang pinag-uusapan nating ligand ay LDL. So, for example, these are LDL molecules. These are LDL molecules. Since LDL can bind to the receptor of the liver, ang tendency ma-activate yung receptor na to. Question, ano bang kayang gawin ng receptor na to? Ang kayang gawin ng receptor na to ay endocytosis. Ang kayang gawin nito ay endocytosis. Can you follow me? Nasusundan? Nakikinita nyo na yung mangyayari pag nag-bind at nag-endocytosis? Nakikinita nyo yung mangyayari dito? Yes or no? Explain natin para magets ha. Ano meaning na endocytosis? Papasok ba sa liver yung LDL? Papasok ba sa liver LDL? Yes, very good. Pag pumasok ang LDL sa liver, anong meron sa LDL? Ano nga meron sa LDL? Kole or anong klaseng lipid? Cholesterol. So question, pag pumasok ang LDL sa loob ng liver, magkakaroon ba ng alternative source ng cholesterol ang liver? Yes, very good. So that causes an increased hepatic cholesterol level, a hepatic cholesterol level that would be needed for bile acid synthesis. And of course, makinig, of course, kapag tumaas ang hepatic cholesterol, bababa ang blood cholesterol. Kasi nga, nagpasukan sa liver, naiwasan sa blood. Okay? So bumaba siya, napunta sa liver. Ganun ang nangyari sa alternative source. That is why kung babalikan natin yung figure na to, o makinig guys, kung babalikan natin ang figure na to, hindi ko na-explain kanina pero part yung area na to sa dinidiscuss ko. Pansin nyo ito, o tingin sa PowerPoint, tingin muna kayo sa PowerPoint. Guys, nakikita nyo tong hina-highlight ko ng color green. Kita nyo to? Ha? Yan yung sinasabi ko na alternative source ng liver. Ang ginagawa ng liver, pinaparami niya yung LDL receptor, kaya yung LDL na a-attract doon sa receptor. So pag na-attract, kakainin ng liver. So in other words, trap siya. Trap. Okay? Gagamitin lang siya ng liver kapag hindi na sapat yung primary source. So overall guys, these are the sources of cholesterol by the liver for bile acid synthesis. The primary is this one, and then secondary, gagamitin ito pag hindi enough ang primary. Tandaan nyo yan ha, related siya sa drugs mamaya. So alternative sources is to increase HDL and then increase hepatic LDL receptors. Gets? Naintindihan? Okay, very good. So before we continue our discussion, let's have a 5-minute health break. I hope you can still learn from me. Balik tayo after 5 minutes, so it's already 8:32. So please be back at 8:37. Is it okay? Okay, overall, we were able to finish the physiology of handling lipids. I hope yung mga knowledge and concepts na na-discuss natin kanina may apply nyo later sa drugs. So at this point, let's proceed on the condition called dyslipidemia. Dyslipidemia is a general term pertaining to abnormal lipid levels in the bloodstream and is a major risk factor in the development of coronary artery or coronary heart disease. As we remember, ang topic natin ay hematologic pharmacology. So that's why dyslipidemia is related there because it focuses on abnormality in the blood, such as abnormal blood lipid levels. And remember that this is a major risk factor in the development of coronary artery disease. Remember, in coronary artery disease, may problems sa coronary arteries because of obstruction. And one of the causes of obstruction is deposition of dead macrophages or oxidized LDL. Okay? And that could lead to angina pectoris. Diba naalala nyo to before? Angina pectoris. And even worse, this could result to myocardial infarction or yung heart attack. Okay? That could result to heart attack. Kaya we have to monitor blood lipid levels. So in connection to dyslipidemia, we have different terminologies that you must remember about dyslipidemia. Number one, we have the term hyperlipoproteinemias. These are metabolic disorders that involve elevations in any lipoprotein species. So pwede dito mataas ang VLDL, ang LDL, etc. Kaya ang term ay hyperlipoproteinemias. And then we also have hyperlipemia. Ang hyperlipemia ay specific sa triglycerides. So in particular, there is increased levels of triglycerides. So we have two classifications of hyperlipemias. So we have the primary. Primary is genetic. Okay, genetic. Kaya nga nakalagay dyan, inherited gene defect. Okay, inherited gene defect. And secondary, more of metabolic disorder. So metabolic disorder, so related na to, meron tayong connection sa lifestyle, ay sa lifestyle ng tao. So halimbawa, increased fat intake o kaya sedentary lifestyle or di kaya Ano pa ba yung mga possible? Obesity, so related yun lahat. Okay? Or smoking, pwede din. So mga influenceable factors. So these are some terminologies. And eto, na-discuss ko na kanina, atherogenesis is the process of forming atheromas. Atheromas is degeneration of the walls. Okay? Degeneration of the walls of the arteries caused by plaque formation, a plaque formation in the walls. So na-discuss ko kanina, what's the reason behind plaque formation? That is because of macrophages na lipid-laden that underwent apoptosis, okay? That underwent apoptosis. So that is atherogenesis. And because of atherogenesis and because of deposition of oxidized LDL here, that has caused obstruction in the coronary arteries resulting in coronary artery disease. Ang coronary artery disease, na-discuss to sa angina, paulit-ulit na natin sinasabi, pero ito ay caused by obstruction in the coronary arteries that deliver oxygenated blood to cardiac myocytes. So because of the obstruction, there is lesser oxygen that reaches the cardiac myocytes. Kaya ang tendency, may pain na nafe-feel yung patient because of ischemia o kaya due to ischemia or infarction. Okay? So yun yung chest pain kung tawagin or angina pectoris. Primary risk factors are hyperlipidemia, hypertension, smoking, obesity or overweight, and then sedentary lifestyle. So ang focus natin dito ay hyperlipidemia, of course. Hypertension, okay na yan, na-discuss na natin before. And then overweight, somehow related sa hyperlipidemia. Okay? And this table summarizes the normal values as well as the abnormal values sa mga lipid levels. So I will no longer focus here. Guys, wag niyo na masyadong kabisaduhin ito kasi may clinical pharmacy naman kayo that will explain or discuss this one. Okay? So next, proceed tayo sa therapeutic strategies in treating secondary hyperlipidemias. Why do we focus on secondary? Kasi ito nga yung influenceable. Ito yung modifiable. Yung primary kanina, take note, yung primary, yun ay genetic na. We cannot do anything else kasi it's really bound or meant to happen. Kasi it runs in your family or genetic na kasi siya. Unlike ng secondary influenceable, so we can modify it actually. So meron tayong pharmacologic and then non-pharmacologic interventions. Siyempre, familiar kayo sa non-pharmacologic, yung mga usual na sinasabi sa atin to manage blood lipid levels. Number one, diet. Siyempre, diet. Restrict from eating cholesterol, rich in cholesterol meals and also triglycerides. And then, sugar. Okay, sugar intake. So marami ng mga evidences or studies na nagsasabing related ang diabetes sa obesity. Okay? Kaya part sila ng metabolic syndrome. So usually yung mga pasyenteng mataas ang lipid levels, subject sila in diagnosing or for diagnosing diabetes. Kaya kung may kakilala kayong merong diabetes mellitus, lalo na yung mga chronic na, yung matagal na, usually binibigyan sila ng gamot for lipidemia or hyperlipidemia. If you know someone, family members na may diabetes at medyo let's say, obese sila o malalaking tao sila, perhaps binibigyan din sila ng lipid-lowering drugs. Okay? So siguro some of you can relate. And then, one of the recommendations as well is to cease from smoking. And of course, meron tayong pharmacologic intervention that is introduction of drugs. There are patients, take note ha, there are patients na enough na ang non-drug therapy. Sasabihin lang mag-diet ka, mag-exercise ka, but for some patients na really at risk, okay, kailangan ng samahan ng gamot. So in relation to that, we will discuss later the different agents that can be used for the management of hyperlipidemias. Okay? So overall, ang ultimate effect ng pharmacologic and non-pharmacologic ay prevention of myocardial infarction. Kasi ang myocardial infarction or atake sa puso, that could result to death. Okay? Ito yung nararamdaman ng pasyente na kumikirot ang dibdib na sustained like it lasts for about 20 minutes. It lasts for about 20 minutes. So sobrang tagal nun. And subject na siya for MI. Yan na yung may STEMI. Di ba may activity ako before non STEMI and STEMI? So yun yung nangyayari. Ayun yung magiging result. So that could result to death. So that's why we really need to intervene the situation by using drugs. So under lipid-lowering agents, we have 6 groups. Or actually, I will just discuss the first 5 kasi these are the ones currently useful. So number 1 are the HMG-CoA reductase inhibitors. Second are the bile acid binding resins. Third, we have niacin. Next, fibrates and ezetimibe. So unahin natin class ang HMG-CoA reductase inhibitors. Simply, these are so-called as statins. Simply, these are called as statins because these are the drugs that end in statin. Examples are lovastatin, pravastatin, simvastatin, and other related statins indicated in the slide. Okay? So let's discuss the mechanism of action of HMG-CoA reductase inhibitors. Apparently, may idea na kayo what could happen by using statins kasi nag-invest na tayo kanina sa physiology. Am I right, everyone? Meron na ba kayong assumption what could happen here? Okay, so let's see. So ang HMG-CoA reductase inhibitors, these agents have this mechanism. They block reduction of HMG-CoA into mevalonate. So binablock nila ang enzyme na HMG-CoA reductase. That's why ang mevalonate formation is inhibited. Question, if mevalonic acid production is prevented, do you think yung cholesterol production ay mangyayari pa or not anymore? Yes or no? No, very good. So hindi na mangyayari ang cholesterol production. So that's basically the MOA of HMG-CoA reductase inhibitors. The mechanism is quite easy to understand because na-discuss na natin kanina yung prosesong ito. But ang medyo challenging yung effects. Ano yung pharmacological effects with the use of statins? So in connection to that, i-discuss natin ang pharmacologic effects ng statins. So number one, with the use of statins, it is expected that the synthesis of cholesterol is being reduced. Okay, so napapababa natin ang cholesterol being synthesized. And of course, pag mababa ang cholesterol, it is expected that the carrier of cholesterol would also be reduced. Kaya ang LDL, as in yung blood LDL, ay yung serum or yung blood LDL, ay bumababa rin. Okay, bumababa. Nasusundan? Okay, continue natin. So after decreased cholesterol and decreased LDL or blood LDL levels, what else? Please remember that the target of statins is the de novo synthesis. Naalala nyo kanina yung de novo? Di ba ito yung de novo synthesis? So, ang de novo synthesis ay ang primary source ng liver ng cholesterol. So, if we are going to use statins, de novo cholesterol synthesis won't be enough. Okay? Would not be enough. So, therefore, ang effect ng statins ay magagamit ng liver ang kanyang alternative sources. Okay? Gagamitin ng liver ang alternative sources. So what could happen pag ginamit ng liver ang alternative sources? May effect ba sa HDL? Magkaka-effect ba sa HDL? Yes or no? Yes, very good. Ano mangyayari sa HDL pag ginamit ng liver ang alternative source? Taas or baba? Okay, very good. So tataas. Kaya you can expect that by using statins, we can enhance HDL levels. We can enhance HDL. Nagets ba't napapataas ng statins ang HDL? So, di ba, related siya. Okay? So, statins have the ability to increase HDL levels. And aside from that, By enhancing LDL receptors, napapababa din niya syempre ang blood LDL. So these are the pharmacological effects held by statins. Okay? So what else? Ano pa yung important factor to consider about statins? That is, related ito sa time of taking the drug. Okay, time. In general, we have to take statins at night. Okay? In general, we have to take statins at night. Gets nyo bakit during at night? Yes, that's right. O bakit siya at night? Kasi yung tinatarget niyang pathway, ito ay at peak, mataas siya on its peak at night. Okay, tuwing gabi siya. So that's why we need to take statins in general at night. However, we have certain exceptions. So remember that statins are drugs ending in statin. And generally speaking, makinaga, generally speaking, ang half-lives ng mga statins in general ay 1 to 3 hours. Yung half-lives sila in general. Kaya it is really important that statins in general should be taken at night kasi ang bilis lang nila umepekto. Imagine niyo kung iinom kayo ng alas 8 ng umaga, active yung gamot ng alas 8 na umaga, pero pagdating ng gabi, wala na, na-eliminate na siya sa katawan. So nonsense. Kaya these agents have to be taken at night. However, we have exceptions. So this include atorvastatin and rosuvastatin. Note that atorvastatin and rosuvastatin are said to be long-acting statins. Why? Because ang half-life sila ay matagal. Okay, matagal. Kaya long-acting sila. Say for instance, for atorvastatin, its half-life is 14 hours. Okay, 14 hours. And then ang rosuvastatin, its half-life takes about 19 hours. So ang Ator, it's 14 hours. And then rosuvastatin, ang half-life niya ay 19 hours. So with this being said, ano ang ating inference? Ang Ator at Rosu, theoretically speaking, pwede ba silang inumin any time of the day? Yes. So ideally, pwede silang inumin anytime. Umaga, tanghali, hapon, okay lang. Kasi pagsapit ng gabi, nasa katawan pa rin natin sila. Pero syempre, as a general rule, pinapasok na rin natin sila sa recommendation na at night. Pero at least alam nyo na may mga exceptions na pwede anytime of the day. Naintindihan po ba ako? Alright, so yan ang agents na exception. That's why, kung meron kayong kakilala na nagtitake ng statins, pansin nyo sa mga presyo ng statins, ito yung mga high class, yung mga pangmayamang statins, mga mahal talaga sila. As in, malaki yung price difference sila compared sa mga simvastatin, sa pravastatin, and so on. Okay? So moving forward, sa third bullet tayo. Also, statins absorption can be enhanced by food. Kaya usually tinitake ito after meals. Pero may exception tayo, that is pravastatin. Okay? And amongst the commercially available statins, the most efficacious or the most effective is rosuvastatin. So in connection to that, ito na-discuss ko na to. Okay, na-discuss ko na to lahat. Okay, na-discuss ko na to lahat. So anong sabi natin? Guys, anong sabi natin? Reduce cholesterol synthesis. Na-discuss ko ba to kanina? Ha? Yung reduce cholesterol synthesis? Yes. Etong naka-box ng green, na-discuss ko ba yan? Upregulate LDL receptors. Everyone, naintindihan nyo na yung ibig sabihin ng bullet na yan? Okay na yan? Ha? Nandyan pa ba kayo? Ha? Okay, very good. Kaya important yung physiology kanina. Okay? However, ang increase in HDL, yes, napapataas ang HDL pero modest lang or small increase lang. Okay? O dito na tayo sa clinical applications of statins. Take note that statins are considered as the first-line agents in the management of hypercholesterolemia, and this can be used as agents that could be or these agents can be used for the stabilization of atheromatous plaque formation in patients with CAD. Okay, so necessary treatment in CAD. Usually, ginagamit sila from 4 to 6 months. Okay, 4 to 6 months for stabilization of atheromatous plaque. Next, let's proceed to the adverse effects with the use of HMG-CoA reductase inhibitors. So number one, HMG-CoA reductase inhibitors are potentially hepatotoxic. Okay? So potentially they are hepatotoxic. That's why it is essential na kailangan i-conduct ang liver function test. Okay? Kailangan i-conduct ang liver function test determination. So we really need to conduct liver function test determination to check if there could be changes in the enzymes, hepatic enzymes. So examples ng mga mini-measure dito yung AST and also ALT. Okay, so yung AST at ALT. Don't worry, madidiscuss ito sa clinical pharm. Na-clinical pharmacy na ba kayo? Okay, so familiar kayo sa ALT, AST, yung sagot saka SGPT, familiar kayo doon? So very good. So yan yung mga liver function tests. So in general, ang ginagawa dito, para lang maalala nyo, before therapy, bigyan ko lang kayo idea, before giving statin to the patient, this will be measured. May measure siya. So ang tawag doon, baseline determination, baseline level. Now, pag na-measure ang baseline AST at ALT level, yan ang basihan if statins will be toxic already. So therefore, during therapy, habang iniinom ng patient ang statin, i-compare yung value during therapy from the baseline. Kasi ang from the baseline, bago ka uminom di ba? Bago ka uminom ng statin. So when the time comes na pag mineasure ang amount ng ALT, AST during therapy at mas mataas ito significantly compared sa baseline, that is the evidence that statins are toxic in the liver already. Naintindihan? Naintindihan? Okay, question. Paano pag hindi na-measure ang baseline? Malalaman mo ba toxic na ang statin or hindi? Hindi mo malalaman kasi wala kang basis of comparison. Parang sinabi mo na mahal ako ni Maria, mahal ako ni Pedro, pero wala kang basihan, wala kang okay? So kailangan may comparison. Hindi siya feel ko ganito, okay? Feel ko ganyan. Okay? So kailangan ng baseline. Next, ang mga statins, they can also cause myotoxicity. Myo means liver. Okay, liver. Sorry, not liver, muscle. Sabaw na ako. Muscle. Such as muscle pain, myositis, and even worse, we have rhabdomyolysis. So sa rhabdomyolysis, there is breaking down of skeletal muscles. So lumiliit na ang size ng skeletal muscle ng tao, and this could result to hyperkalemia. This could result to hyperkalemia and also acute renal failure. Okay? So isa pang effect is acute renal failure. So acute renal failure, that means renal damage. Okay? Renal damage. And then HMG-CoA reductase inhibitors could also interact with CYP inhibitors, cytochrome inhibitors, which could cause enhanced toxicity caused by statins. Enhanced toxicity caused by statins. And finally, these agents are teratogenic. Okay, teratogenic. Meaning to say, they can adversely target developing fetus. Hence, this should not be given to women who are pregnant, even lactating, and expectant mothers. In fact, ang rosuvastatin ay pregnancy category X. So meaning, proven toxic, proven teratogenic sa animals and also humans. Okay? Kaya pregnancy category X siya. So altogether, that ends the first group of hypolipidemics. So X na tayo sa HMG-CoA reductase inhibitors. Naintindihan ang pharmacology ng statins? Okay, moving on, we have bile acid binding resins. So everyone, dito na po tayo sa bile acid binding resins. Bile acid binding resins are also known as bile acid sequestrants. Okay? These are also known as bile acid sequestrants. Examples are cholestyramine, cholestyramine, and finally cholesevelam. So bago natin i-discuss yung mga succeeding slides about bile acid sequestrants, some important notes to remember about sequestrants na basic na maa-apply natin sa mga susunod na slides. Number one, ang bile acid sequestrants, ito ay taken by mouth. Okay? Taken by mouth. So as expected, if taken by mouth, you can predict na ang journey ng gamot ay from the mouth, esophagus, stomach, intestine. However, makinig, ito yung highlight sa mga sequestrants. They are non-absorbed. Okay? They are non-absorbed by the body. Sir, anong ibig sabihin ng non-absorbed? That means, nakakasunod pa ba sa akin? Ha? Very good. So pag sinabi nating non-absorb, pag tinik by mouth ng pasyente yung bile acid sequestrant, it will not enter the blood. Di ba natutunan nyo sa kinetics, pag nasa small intestine na siya, dapat pupunta siya sa bloodstream for absorption and distribution. But in the case of sequestrants, pagpunta sa mouth, pagdaan sa mouth, para lang siyang dumaan sa GI tract mo. Dadaan lang siya sa GI tract and then sasama na siya sa stool. Itatae mo na lang siya. So dadaan lang siya. Okay? Hindi siya pupunta sa iba't ibang parts ng katawan natin. Na-gets yung term na non-absorbed? Okay, very good. What else? What else? Ang analogy ko usually about sequestrants, they are like magnets. Okay? They are like magnets. So take note, they are like magnets. So they promote adsorption. Okay? They promote ad as in dog, adsorption of compounds into their surfaces. Okay? They promote adsorption. So palatandaan pag adsorption, dumidikit ang compound sa surface. Okay? Dumidikit ang compound sa surface. So they are like magnets. Okay? They are like magnets. So for example, again, makinig, for example, etong color green yung bile acid sequestrant. Again, this color green is the bile acid sequestrant. Now, pag tinik ng tao, ang bile acid sequestrant, may mga certain compounds sa GI tract natin, na pwedeng ma-magnetize sa surface, ma-adsorb sa surface ng mga bile acid sequestrants. Maaari silang tumikit. Kaya they are like magnets. They are like magnets. Gets po ba ako? Okay, let's continue. Ano ang example ng compounds na pwedeng ma-magnetize, maaaring dumikit o ma-adsorb kay cholestyramine for example? Siyempre, bile acids. Kaya nga ang tawag ay bile acid sequestrant. Kasi ang bile acid ay nag-a-adhere sa surface ng mga gamot na ito. So overall, what would happen kapag ganito ang action ng bile acid sequestrants? This makes us realize that whatever happens, makinig, whatever happens to the sequestrants, bile acid will follow. Siyempre, ang fate ng mga sequestrants ay tinatai lang sila, kaya ang bile acids mismo, tinatai lang din natin. Naintindihan nyo ba? Okay, so dyan iikot ang mechanism of action ng mga bile acid sequestrants. So if you are genuinely listening and actively participating to our discussion, meron kayo mga certain predictions sa action ng mga sequestrants. Okay? So moving on. So this figure explains the mechanism of action of bile acid sequestrants. In short, ang bile acid sequestrants, they have the ability to inhibit the process biliary recycling. Okay, they have the ability to inhibit the process biliary recycling. Yes or no? Naalala ang biliary recycling? Yes, okay. So balikan natin. Ang biliary recycling is the process of reabsorption of majority ng bile acids. So basically, pag gumamit ka ng bile acid sequestrants, dahil nga magnet sila, dahil magnet sila, somehow ang iisipin nyo dito, yung 95% na nare-reabsorb, sila ang naidudumi. Sila yung nailalabas. Okay? Ang bile acids na marami na itatae o na ilalabas. At ang nare-reabsorb, yung 5% lang ang nare-reabsorb. Okay? Nare-reabsorb. So what could happen kapag na-block ng sequestrants ang biliary recycling? That could result to decreased reabsorption of bile acids. Okay? That reduces reabsorption of bile acids. Ulit, sa anong compound derived ang bile acid? Sa anong compound? Yes, that's right. So ito ay derived sa cholesterol. So ano kaya ang pwedeng mangyari? Kapag konti ang bile acid na bumalik sa liver, question, matitrigger ba ang liver na gumawa ng maraming bile acid pag konti ang bumalik sa kanya? Will it trigger the liver? Will it stimulate the liver to produce more bile acid? Yes, very good. So it enhances bile acid synthesis. Okay? It enhances bile acid synthesis. Now, kapag marami siyang ginawang bile acid, pakinggan niyo mabuti sasabihin ko ha, pag na-trigger ang liver na gumawa ng mas maraming bile acid, mas needy ba siya? Mas nangangailangan ba siya ng cholesterol? Yes or no? Yes, it will need more cholesterol. However, ito yung problema. Gawa ng cholesterol ang liver, pero tapon naman ng bile acid. Okay? Gawa ng bile acid rather ang liver, pero tinatapon ng bile acid. Kaya darating ang time na yung sources ng cholesterol ng liver hindi na enough. Kasi tinatapon. Kaya ultimately, ang effect ng bile acid sequestrants ay decrease in blood cholesterol. They can also increase HDL because of utilizing alternative sources and also decrease LDL. Okay? And also decrease LDL. Naintindihan? So yan yung bile acid sequestrants. Okay? Type in done if you are finished copying. Okay, so next. So amongst the stated examples, we shall focus on cholecephalam. So meron tayong additional use for cholecephalam. O tandaan nyo na lang sa slide na to, na-discuss ko naman na to lahat. Pero for cholecephalam, siya ay anti-diabetic din. Ay anti-diabetic. So this is also an anti-diabetic agent. Amongst the three examples, siya ang proven anti-diabetic agent. However, the specific mechanism related to that is still unknown. Okay? Pero proven na siyang useful for diabetes mellitus. So moving on, let's proceed to the clinical uses and effects and clinical uses of bile acid sequestrants. Actually, na-discuss ko na to. Check nyo ha. Cholestyramine and cholesterol, for example, lower cholesterol and LDL. Okay? They can lower cholesterol and LDL. Na-discuss ko siya kanina. Okay? However, distinct to bile acid sequestrants, they can increase triglycerides, VLDL levels. Okay? They can increase triglycerides and also VLDL levels. So, to address this, usually ang mga bile acid sequestrants, they are being combined with niacin. Because niacin, this will be discussed later, pero tandaan nyo sa ngayon, this agent can lower triglyceride levels and also VLDL. Mamaya, yung mechanism related to that will be discussed. Okay? So, ang bile acid sequestrants, they can be combined with niacin to lower elevated triglycerides and also VLDL. And finally, bile acid sequestrants can also increase HDL levels by utilizing alternative sources. Okay? What else? These agents can also be used in relieving pruritus in patients with with cholestasis or cholestasis, and also bile acid accumulation. Okay? Cholestasis and bile acid accumulation. And finally, these agents can be used as antidotes. They can be used as antidotes during digitalis toxicity. The mechanism is still the same. Since ang mga sequestrants ay non-absorbed, ang isang pwedeng dumikit pa na compound sa sequestrant ay yung digoxin, for instance. Okay? Pag dikit ng digoxin, maidudumi ba ang digoxin pag dumikit siya sa resins? Yes. So, effective ba yun during toxicity? Yes, of course. Okay? Kaya pwedeng gamitin. However, it does not include cholesevelam. Okay? It does not include cholesevelam. Moving on, adverse effects. Toxicities caused by using these drugs could somehow be connected with gastrointestinal problems. Gastrointestinal kasi nga non-absorbed naman siya. Kaya may unpalatability, bloating effect kasi nga naiipon sa tiyan o sa intestine, and constipation. Next, there could be, o nasabi natin to kanina, there could be a chance that triglyceride levels could be increased, and then there could be malabsorption of fat-soluble vitamins, and these are the ADEC vitamins, and certain drugs. This could be explained by the sequestering action of bile acid binding resins. And then we have steatorrhea. Ang steatorrhea ay fatty stool. Okay, ito yung fatty stool kung tawagin. So evidence sa dumi, yung effect ng mga bile acid sequestrants kasi nga dumidikit yung taba. Okay, dumidikit yung taba. Kaya makikita niyo yung stool, may taba talaga siya. Okay? May taba, hindi mataba. Magkaiba yung mataba at may tabang stool. Magkaiba yon. May taba. So yon. And then finally, ang cholesevelam particularly is pregnancy category B. Ang pregnancy category B ay proven safe to animals, and then sa humans, hindi pa tayo sure kung safe siya o hindi. So overall, done with bile acid sequestrants. Next, let's proceed to niacin. Everyone, pwede na kay niacin? Ha? O sige, medyo bilisan natin kasi we only have 15 minutes remaining. Guys, ang niacin is also known as vitamin B3. And let me tell you that we have two forms of B3. Ang first form of B3 is niacinamide. A first form of vitamin B3 is niacinamide. And then the second form is nicotinic acid. Now, between the two, the one that possesses hypolipidemic function is nicotinic acid. Siya yung may kakaya magpababa ng lipid levels. Kaya huwag kayong magtataka kung may mga libro na ang pangalan ay niacin at may mga libro ang pangalan nicotinic acid. Isa lang yung meant nila. But technically, the more specific one is nicotinic acid. Okay? So yan yung mga forms ng vitamin B3. So let's proceed to the mechanism of action of nicotinic acid. Nicotinic acid, take note, inhibits synthesis and release of VLDL. Again, this agent inhibits synthesis and release of VLDL. So it can inhibit synthesis and also release of VLDL. And because of this action, this would result to lesser amount of VLDL. Kaya nga sabi ko kanina, we usually combine niacin with sequestrants to address the side effect of sequestrants. That is, enhance VLDL. So ang ginagawa ng niacin, pinabababa niya ang VLDL. It can also decrease LDL. It can also decrease LDL. And most importantly, amongst all, sa lahat-lahat na mga lipid-lowering agents, ang niacin ang may pinakamalakas magpataas ng HDL. Okay? So this is the drug that can increase HDL the highest extent. So yan yung tatandaan natin about the effects of of niacin. So another figure that would explain the action of niacin. So una na-discuss natin, it can inhibit, it can inhibit synthesis and also release of VLDL. Why or how? Paano? So that is because niacin can block or can lower adipose tissue fatty acid mobilization and decrease fatty acid esterification. Pag sinabi nating esterification, that is the process of making triglyceride. Okay? So that is the process of making triglyceride. So ang tawag din doon ay lipogenesis. So ang tawag din doon ay lipogenesis. So pinabababa yon ni niacin. Question, kapag pinababa niya ang lipogenesis, mataas o mababa ang triglyceride produced? Mababa, very good. So mababa ang triglyceride produced. So it is expected na pag mababa ang triglyceride, mababa ang triglyceride sa liver. Okay? Bumababa ang triglyceride sa liver. Question, importante ba ang triglyceride sa liver? Importante ba siya? Kailan natin na-discuss ang triglyceride sa liver? Importante ang triglyceride sa liver kasi ang ginagawa niya ay yan yung dinadagdag niya sa remnants. Naalala nyo ba yung kanina, mga bata? Di ba ang chylomicron remnants, dinadagdagan niya ng VLDL para gawing, dinadagdagan niya ng triglyceride rather, para maging VLDL, tama. So I have a question here. Pag mababa ang triglyceride in the liver, kumusta ang VLDL na nagagawa niya? Mataas or mababa? Okay, kaya ang ultimate effect dito ay mababang VLDL and eventually mababang LDL. Okay, mababang LDL. Kaya na-discuss ko kanina, I hope mako-connect natin ito, na-discuss ko kanina na it can inhibit synthesis of VLDL kasi yung source na triglycerides umuunti kasi pinipigilan ng niacin ang lipogenesis. And then, release syempre affected na rin due to lesser amount of triglycerides, and then makikita natin na mababa ang apoprotein B na carrier ng triglycerides. Na carrier ng triglycerides. So that's for the first action. First action of niacin. O second, pwede na po ba sa pangalawa, guys? Okay, si niacin ba ay nagpapataas ng HDL? Yes or no? Yes. O dun tayo sa second mechanism that could enhance, HDL levels. So niacin is the one that can enhance HDL the highest extent. That is because of the following actions. Number one, it binds to HDL receptors, thus reducing catabolism or degradation of the receptor. And by decreasing catabolism of the receptor, yung pag-remove ng apoprotein from the HDL, reduce din. Okay? Important ba ang presence ng apoprotein sa isang lipoprotein such as HDL? Very good, important siya. So by reducing removal, it means nare-retain. Nare-retain yung apoprotein A1. Pag retained ang apoprotein, sulat natin na retained ang apoprotein A1, ibig sabihin, ang HDL iniiwasan mo ma-degrade o masira. Kaya tumataas ang HDL. So that's the mechanism of action of niacin in enhancing HDL. So it focuses on the apoprotein. Okay, so yan yung explanation. Well, yung isang slide na ipapakita natin, ito rin yung sinabi ko kanina. O recap tayo. Anong sabi natin? By using niacin, kumusta ang lipogenesis? Enhanced or reduced? Okay, baba. Very good. So bababa. Pag bababa, kumusta ang ipoproduce na VLDL o ire-repack? Konti o marami? Okay, baba din or konti. Very good. So konti, kaya konti din ang ilalabas. Okay? What about HDL? Ano ang minomodify ng niacin sa HDL? Yung protein component o yung lipid component? Protein component. Kumusta? Iniiwasan niya bang masira o pinaparami niya ang production? Pinaparami ba ang apoprotein portion o iniiwasang masira? Iniiwasan, pinaparami. O, balik tayo sa slide na to ha. Balik tayo sa slide na to. Anong sabi natin? Decrease uptake or removal. Iniiwasang masira. Very good. Iniiwasang masira. Take note of that ha. Hindi niya pinaparami ang apoprotein component, iniiwasan niya masira. So pag iniiwasan masira, eventually dadami sila. Okay, dadami. Kaya nakalagay dito, reduce clearance but not reduce synthesis. Okay, so yun yung ibig sabihin. Therapeutic uses. For the uses of niacin, number 1, this agent serves as an alternative to fibrates. Ang fibrates, madidiscuss natin later, for hypertriglyceridemia. And also, this agent is the most effective in increasing HDL, nasabi ko na yan kanina. And in patients with lipoprotein LPA, hyperlipoproteinemia, this agent can be used because siya lang ang nagpapababa ng LPA. Ang LPA, increased levels of LPA can cause coronary artery disease as well. Okay? It can cause coronary artery disease. Next, toxic effects. Number 1 is flushing or redness. Ang redness, pamumula caused by nicotinic acid is caused by prostaglandin. Okay, prostaglandin. So to relieve redness, we can use NSAID. Okay, to relieve redness, we can use NSAIDs. And in particular, usually ginagamit ay low-dose aspirin. Okay, low-dose aspirin o kaya ibuprofen. Okay, o kaya ibuprofen. Huwag nyo tong kakalimutan kasi common mistake ito ng ilang students. Why? Usually pag naririnig nyo ang pamumula, you always think that it's allergy, right? Kaya pag na-encounter nyo ang question na to, may mga pagkakataon na ang nasasagot nyo ay gumamit ng antihistamine kasi nga namumula baka allergy. No, it's prostaglandin mediated, kaya we need NSAIDs. Do you understand? Okay, kasi COX inhibitor ang NSAIDs. And then there could also be gastrointestinal disturbances, rare na palpitations, and also high doses could cause hepatotoxicity. Kaya kapag merong continuous or chronic use of niacin, liver function test has to be conducted as well. Okay? Okay, number 4. Number 4 na tayo out of 5. Malapit na. Number 4 are the fibrates or fibric acid derivatives. Examples are gemfibrozil, clofibrate, fenofibrate, bezafibrate, and ciprofibrate. So mechanism of action tayo ng fibric acid derivatives. So regarding fibric acid derivatives, take note, marami siyang kayang gawin. Okay? Marami siyang mechanisms. So number 1, it can inhibit triglyceride synthesis and reduce VLDL release into the systemic circulation. So somehow related ito sa ginagawa ng niacin. It can also inhibit synthesis and also release of VLDL. Okay? And then second, it can increase lipoprotein lipase's action. What is lipoprotein lipase? Remember, this is a hydrolytic enzyme. Kaya guys, pag gumamit ng fibrates, what do you expect on the level of blood triglyceride using fibrates? Tataas or bababa ang serum triglycerides? Tataas or bababa ang serum triglycerides pag gumamit ng fibrates? Very good. Bababa. Bakit bababa? Ano yung ine-enhance ng fibrates? Anong ine-enhance niya? Ine-enhance niya ang lipase. Ano bang kayang gawin ng lipase? Nag-hydrolyze ba ang lipase? Ha? Yes. Anong hina-hydrolyze niya? Anong sinisira niya? Chole or triglyceride? Okay, tags. Kaya nasisira siya, nababawasan. Kaya decrease serum triglycerides. Okay? And also it can increase catabolism of triglyceride-rich VLDL, thus lowering serum VLDL. Okay? What else? Also, fibrates, they are called as PPAR gamma agonists. Okay? They are also alpha, not gamma. They are also PPAR alpha agonists. So when we say PPAR, it means peroxisome proliferator activated receptor, and they activate this receptor. So what could happen pag na-activate nila ang PPAR alpha? So there could be modulation in the expression of several proteins. Modulation, it can either enhance o kaya reduce the regulation. Okay? So unahin natin dun sa upregulation, ine-enhance. Okay? Ine-enhance. Because of activating PPAR alpha, these agents can enhance LPL expression. When we say LPL, ito yung lipase kanina. Okay? Ito yung lipoprotein lipase. Ano nga ulit ang expectation kapag enhanced ang LPL? Enhance or reduce triglyceride level? Enhanced or reduce triglyceride level? Okay, reduce triglyceride levels. Next, these agents can also enhance apoprotein A1 and apoprotein A2. Ano yung ApoA1 at ApoA2? Related ito sa HDL. Okay, related ito sa HDL. In fact, ang apoprotein A1 at apoprotein A2, these are the apoproteins of HDL. Question, pag mataas ang pag may upregulation ng ApoA1 and A2, taas o baba ang HDL? Okay, so napapataas ang HDL. Okay? And then finally, napapababa niya ang regulation ng ApoC3. Again, it can lower or it can downregulate ApoC3. Ang ApoC3 naman ay makikita sa LDL. Okay, makikita siya sa LDL. So you answer my question, taas o baba ang LDL? Okay, so bababa. Okay, bababa. Oh, sorry, it's VLDL. Okay, VLDL. Pero anyway, pag bababa ang VLDL, bababa din naman ang LDL. Okay, so pag bababa ang VLDL, bababa din ang LDL. So related pa rin sila. So ApoC3, ang direct effect niya sa VLDL, and then after that, we have LDL. So yun na yun. Okay, yun na yung summary ng MOA ng mga fibrates. So itong slide na to, nasabi ko na yan, ApoA1 and ApoA2. Okay? And then, mechanism of action, ito na rin yung summary. ApoA1, ApoA2, increase HDL. Nagets ba ako? Ha? ApoA1, ApoA2, HDL. Now, anong difference ng fibrates sa nicotinic acid kanina? Ang nicotinic acid, decrease clearance. Iniiwasan ang pagkasira. Pero ang mga fibrates, pinaparami ang production. Yun yung difference nila. Okay? And then, decrease ApoC3, decrease VLDL, and then, LDL, bababa din. O, yun na yun. Okay? So, yun din itong slide na to. Paulit-ulit lang siya. Basta tandaan nyo, because of activating PPAR alpha, these effects will happen. Modulation of proteins. More on apoproteins ang target niya. Therapeutic uses. These agents are the first line, take note, these agents are the first line for hypertriglyceridemia, and also they can be used in the management of metabolic syndrome. So they can also be used in the management of metabolic syndrome. Next, pwede na sa susunod? Ha? Pwede na? Okay, toxic effects. Toxic effects, rhabdomyolysis, and then bile stone formation. There could be gallstone or bile stone formation, and then mild gastrointestinal syndrome. Symptoms. For clofibrate, take note, for clofibrate, use of clofibrate is associated to hepatobiliary cancer. Okay? Use of clofibrate is associated in the development of hepatobiliary cancer. Okay? And finally, last drug na tayo. Ito na yung number 5. Number 5, the last drug is called ezetimibe. Ezetimibe is a sterol. Okay? This is a sterol absorption inhibitor. Okay, this is a sterol absorption inhibitor. Ang ezetimibe is a sterol absorption inhibitor because it inhibits the transporter code Niemann-Pick C1 like 1. Okay, so it inhibits Niemann-Pick C1 like 1. I repeat, ezetimibe is a sterol absorption inhibitor and it inhibits Niemann-Pick C1 like 1. Now, ano ba yung Niemann-Pick C1 like 1? Ang Niemann-Pick C1 like 1, this is a transporter responsible for the passage or pagdaan ng fats from the small intestine going to the blood. So, yan ang Niemann-Pick C1 like 1. So, it is a transporter that allows entry of cholesterol and triglycerides from the small intestine to the blood. So in other words, yung kinakain natin ng mga pagkain na may fats o kaya other lipids, yung entry nun sa blood ang pinipigilan ng ezetimibe. Kaya nga siya absorption inhibitor. Gets ba? Okay? So usually ginagamit ang ezetimibe as an add-on therapy to statins. So when we say add-on to statins, usually kino-combine ang ezetimibe with statins. In fact, meron tayong commercially available drug na combined ang statin at ang ezetimibe. Particularly, that is the brand Vytorin. Ang generic name ng Vytorin ay simvastatin, and ezetimibe. I repeat, for Vytorin, that is the combination of simvastatin and ezetimibe. So ang purpose of combining them is, number one, meron silang dual inhibition. First, under dual inhibition, we have inhibiting production of cholesterol. This is through simvastatin's action. Okay, because of simvastatin's action. And then inhibition of absorption is caused by ezetimibe. Kaya pinagko-combine sila to enhance hypocholesterolemic effect. Next, adverse effects, myositis, low incidence of hepatic dysfunction. Okay? O wag niyo nang aralin yung Probocol, ano siya hindi naman na siya useful nowadays. It's not useful nowadays. So, wag nyo nang aralin yung Probocol. Ang laking tulong, no? Ng 2 linya sa slide na to. So, wag nang aralin yan. And then, last slide. Pwede na sa last slide. Okay, so last slide, combination therapy lang naman. Actually, maiintindihan nyo to pag na-grasp nyo, hopefully, yung mga diniscuss nating actions ng mga hypolipidemics. So number one, when VLDL levels are significantly increased, we can use resins. And then when LDL and VLDL levels are both elevated initially, we can combine certain medications that address LDL and VLDL. And then when LDL or VLDL levels are not normalized by single agent, and then when elevated LPA and HDL deficiency coexist. So ang point lang sa slide na to, ito yung mga considerations nyo in combining hypolipidemics. Okay? So you just have to consider the pharmacologic actions of each group kung match ba silang i-combine. Ayan. So overall, finally, tapos na tayo sa drugs for dyslipidemia.